Hello, everyone. Welcome to our webinar partnering with NTNC. We are Heartland National TV Center, and we are so very glad to have the opportunity to drop some knowledge on all of y'all this afternoon. First, allow me to introduce myself. My name is Lauren Warren Fields. I am a training and education developer here at Heartland National TV Center, and I will be working in partnership with our presenters today. So if you would be so kind, everyone, if you could tell us where you're from in the chat box real fast. We like to see where all of our friends are because we know that we're expecting people from all over. Usually we get to see just Texas people since we're contracted through the state of Texas. But since this is a national scope webinar here, we're excited to know where you're all from. And if you will be so kind as to just stick with me while I make sure that I introduce ourselves formally, since, like I said, we are contracted through the state of Texas, but not everyone is from Texas. And so I want to take the opportunity to make sure that we properly introduce ourselves here. Before we begin, thank you all for joining us for Undressing DRESS, When Medications Dress to Kill. This is a webinar that is jointly sponsored by the following TB Education and Training Centers, as well as the National TB Nurse Coalition, also known as NTNC. Now, specifically at Heartland National TB Center, our mission is to build capacity with our partners. We will share expertise in the treatment and prevention of tuberculosis by developing and implementing cutting-edge trainings, delivering expert medical consultation, providing technical assistance, and designing innovative educational and consultative products. Our vision is to provide excellence, expertise, and innovation in training, medical consultation, and product development to reduce the impact of tuberculosis in the state of Texas. So let's talk about that real fast for some of our medical consultations. Now, those of you in Texas and who are not already aware, we cover the following health service regions. And you'll see on here that our presenters, the same three wonderful ladies who will be sharing some information with us later, have essentially divvied up the regions amongst themselves. So if you recognize a region in there, just take a quick look up at who your nurse is and be sure to contact them if you ever have any questions regarding medical consultations. And of course, if you are curious about medical consultations, here is our consultation line, which is available Monday through Friday from 8 a.m. to 5 p.m. And we try to respond within 24 hours. Of course, the weekends are not included on that. Give us a break. Now, Dr. Seaworth, Dr. Armitage, and our other medical consultants are experts in TB, multi-drug resistant TB, pediatric TB, and TB comorbidities, including TB with HIV and TB in patients with medical health issues. Regarding training and education, while we do offer webinars, we also offer some core courses throughout the state of throughout the year within the state of Texas. And if you are within Texas, these are for free, so just keep that in mind. Most of our trainings are for free, but especially within Texas. Our core courses include Introduction to TB Nurse Case Management Online, Essentials of TB Nurse Case Management Online, and TST, Training the Trainer with Practicum, which are held 2 to 3 times a year in San Antonio, Texas. And of course, other courses like the one that we have here are developed and implemented in collaboration with any host health department or agency. And of course, we also try to cover webinars covering a variety of topics. So here is just a few of some of what is coming up immediately. So my Texas people, take note, and some of y'all who might be near a border city or whatnot, you might be interested in this too. And then, of course, we offer technical assistance. So this means that we help programs with course development and by providing resources for programs or partners to deliver trainings and planning calls. We also offer a variety of educational resources which can be downloaded straight from our website. And of course, anyone within the state of Texas, and that includes agencies within the state of Texas, we can ship to y'all free of charge. Everyone else, unfortunately, our state does not allow us, or our state contract does not allow us to cover shipping costs outside of the state. So just keep that in mind, please. As far as our online presence is concerned, you can find us a variety of ways. So for instance, you have our official website where you can view upcoming and archive trainings. Speaking of which, this meeting is being recorded, and once it is officially approved for publishing, you can find a recording of this webcast via our official website, via the training archives page, and on our official YouTube channel. You can also gather information about our consultation services that I mentioned earlier, access those educational resources to figure if you are at all curious, as well as find contact information for not just our speakers for today, but anyone on the Heartland team. And then I would be remiss if I did not direct everyone to join Heartland on our official Facebook account. We are trying to post so many updates about what's going on as far as exciting events, fun facts. And if you have not already done so, please drop by, give us a like, and share what we have to offer via that page. Now, as far as course information is concerned, let's talk a little bit about undressing dress when medications are dressed to kill. This webinar does have the Q&A pod active, but if for some reason you are unable to access the Q&A pod, just keep in mind that the chat will be monitored as well, so you can always drop a question for any of our presenters within the chat if your Q&A pod is not available. But we do ask that if you have a question, please go ahead and drop it there. Otherwise, we'll just migrate it for you. And then just know that there might be photos and videos taken during the webcast. And since it is recording, I don't believe anyone is going to be on film or really on the recording aside from myself and our three nurses. So just keep in mind that if you have an issue with that whatsoever, please let me or any Heartland staff member know, and we will take that into account. And then, of course, let's talk about our leading lovely ladies for this webcast. So first off, we have Catalina Navarro, who has served as a manager for an outpatient medical center for 8 years in Bogota, Colombia. Once in the US, she worked as a gastrointestinal and vascular nurse at a local hospital in San Antonio for 3 years. Since 2016, Catalina has served as a nurse consultant and educator at Heartland National TB Center and assists in the case management of US and Mexico TB patients. And of course, Catalina does not have any disclosures to make regarding her presence here and any of the content that she has to present. And then we have Debbie Davila, who has more than 19 years of experience providing care to patients diagnosed with TB disease. Her previous TB experience includes serving as a charge nurse at Texas Center for Infectious Disease and as a senior public health nurse for the City of San Antonio Metropolitan Health District, managing care for patients diagnosed with TB disease. Debbie holds a Master of Science in Nursing with an emphasis in public health from Grand Canyon University and a Bachelor of Science in Nursing from the University of the Incarnate Word. And just like Catalina, Debbie also has no disclosures to make. And last but certainly not least, we have Salma. Salma Lerma obtained her Bachelor of Science in Nursing in 2016 from the University of Texas at El Paso. She began her nursing career in the neonatal ICU and then transitioned to TB. She worked at the TB clinic in El Paso, Texas as a nurse case manager, where she found her passion and dedication for helping patients with TB. She obtained her Master of Science in Nursing Education in 2018 from the University of Texas at El Paso, and she continued to work as a nurse case manager at the TB clinic for 4 years. And since 2022, Salma has also served as a nurse consultant and educator at Heartland National TB Center. And of course, Salma has no disclosures to make regarding this presentation. And I just want to say thank you for taking a quick little moment to allow us to introduce myself and our three lovely ladies. And I do want to state that before we officially begin the recording of the content, if you have any questions while the content is underway, please feel free to drop it in the chat. I guarantee you we are all monitoring the chat, and we will be making time at the end to address any questions that are there. So when in doubt, just drop it inside the Q&A pod or in the chat if the Q&A pod is not available for you for whatever reason that might be, and we will be happy to discuss it during the Q&A session at the end of the presentation. But give me 1 second to go ahead and cue that up for y'all.
Hello everyone, and welcome to our Heartland webinar. I wish I could talk about this cute dress that this pretty lady is wearing. Unfortunately, we are here to talk about another kind of dress. Dress as a severe drug reaction that can affect multiple organs and become life-threatening if not recognized early. This is the title of our presentation, Undressing DRESS, when TB meds dress to kill. Let me start with the DRESS definition. DRESS is the acronym that stands for drug reaction with eosinophilia and systemic symptoms. DRESS syndrome is one of the most severe and life-threatening drug reactions that we encounter. It can turn life-saving TB medications into a deadly threat and high risk of mortality if not recognized early. Here at Heartland, we receive 1 or 2 consultations of cases related with DRESS each year, and we have noticed it is becoming more common. That's why it's critical for nurses and healthcare staff to know what to look for. Today, we are going to show you a current case of a patient who had a severe reactions to TB meds. Through this case, we are going to learn how to spot and how to manage DRESS before it becomes too late. Let's undress the mystery behind DRESS. First, most rashes result from an allergic reaction to a medication. The timing of the rash varies. Drug-induced reaction can be classified according with the time of onset. You can find immediate reactions or delayed reactions. Immediate reactions can occur under observation. You have a patient in your clinic, you administer TB medications, and 30 minutes later, the patient starts complaining of itching. You can see a mild rash. You can maybe give Benadryl or use atopic steroids, or it could be a little more serious. The patient starts with urticaria, difficulty breathing. You can see hives, and you must use the EpiPen to treat an emergency of an anaphylactic reaction. So this is an immediate reaction. On the other hand, the delayed reactions occur after more than 24 hours of administering the medication, and DRESS is a delayed reaction. The cases that we have seen at Heartland in consultation or at Texas Center for Infectious Disease are reactions that have started after 3, 4, up to 6 weeks after the medication is started. We have to rule out other drug reactions like the toxic epidermal necrolysis or the Stevens-Johnson syndrome. The actual incidence of DRESS is diverse because it varies depending on the type of drug and the immunity of the patient. The incidence is estimated between 1 in 1,000 to 1 in 10,000 drug exposures. The fatality rate is up to 10%. The main cause of mortality in DRESS is due to fulminant hepatitis and liver necrosis. Signs and symptoms typically begin 2 to 12 weeks after the start of the medication or after increasing the dose. These clinical manifestations can persist for weeks to months after discontinuing the offending drug or after introducing a new drug. DRESS syndrome can happen with many different medications, but how about DRESS related to TB meds? Currently, there are no large number of studies specifically focused on DRESS related to TB medications. Most of the evidence comes from case reports and small case series, no large-scale studies. One of these small studies from an academic medical center in California focused on confirmed and unique cases of DRESS. This study was published in the Skin Health and Disease Journal by the British Association of Dermatologists in 2024. The study found that anti-TB drugs cause 7.5% of all antimicrobial-related DRESS cases. These are the summary of the findings. From 133 unique episodes of confirmed DRESS, 67 episodes were attributed to antibiotics, and 7.5% were attributed to TB drugs. Rifampin was the most common suspected cause, implicated in 80% of the cases. Even though this study was small and done in one hospital, it offers helpful guidance for managing DRESS in patients with tuberculosis. What are the clinical manifestations? The early signs and symptoms are general malaise, itching, macular exanthema, followed by fever and facial swelling. Over time, the skin rash takes on a more purplish appearance associated with diffuse scaling, and in 20 to 30% of the cases, the erythema progresses to erythroderma. 75% of the patients could present lymphadenopathy. Other internal organs are compromised. It could be the liver, the kidney, sometimes the heart, and sometimes the lungs. It can be a reaction that causes severe liver failure with coagulopathy, encephalopathy, ALT greater than 10 times the upper limit. It could be so severe that the liver transplant will be needed. There is also cases where severe interstitial nephritis occurs and progresses to kidney failure. For the patient needed dialysis. Patients with underlying kidney disease and the elderly are at higher risk of presenting kidney failure. The definitive laboratory finding will be eosinophilia and atypical lymphocytosis. Up to 70% of the patients present this abnormal lab. Here are photos of a 70-year-old female patient who was diagnosed with DRESS syndrome last year, around the same time as the patient that we are going to present. The images show her face swollen and a widespread maculopapular rash covering her trunk, the arms, and the legs. These photos highlight how severe the rash can be and show the typical characteristics of DRESS. Skin involvement usually begins as a pruriginous, morbilliform rash, which rapidly progresses, becoming diffuse and infiltrating. To understand DRESS, let's first look at what eosinophils are and what eosinophilia means. Eosinophils are a type of white blood count, and they make up less than 5% of all white blood count in the body. They help the body fight infections, especially parasites, and play a role in allergic reactions. Eosinophilia means having more eosinophils than normal in the blood. It can happen due to infections, allergies, autoimmune diseases, or reactions to medications, like in DRESS syndrome. In DRESS, the body has an exaggerated immune response to a drug, and eosinophils go into overdrive, damaging organs like the liver, kidneys, or lungs. Let's look at the medications that can trigger DRESS. DRESS is most commonly associated with these kind of drugs: antiepileptics, antibiotics, anti-TB meds, and others such as allopurinol, hydrochloroquine, omeprazole, and sulfate. However, among the TB drugs, rifampicin has been identified as the one with the highest risk of developing DRESS. DRESS is a clinical diagnosis based on symptoms and a drug history. There are no confirmatory lab or diagnostic tests for DRESS. Diagnosis involves recognizing a constellation of signs and symptoms. The diagnosis is often supported by the REGIS-CAR scoring system, which helps evaluate the likelihood of DRESS. This slide outlines the diagnostic criteria developed by the REGIS-CAR group, an European consortium that focuses on severe cutaneous adverse reactions. On the left side, you see the clinical and laboratory features as evaluated. You can see here the criteria in the left side. These include fever, lymphadenopathy, skin rash, eosinophilia, internal organs involvement, and other exclusion of other potential causes. On the right side, you will find the scoring system, which assigns points to each of these criteria based on their presence or severity. The total score helps categorize the likelihood of DRESS into one of four categories: no case, possible, probable, or definitive case of DRESS. This structured approach supports consistency in diagnosis and is particularly useful in research and complex clinical cases. When you suspect DRESS syndrome, it is critical to act quickly and systematically. Start with a complete skin exam looking for characteristics findings such as widespread, often morbilliform rash that may be in both the face and trunk. Order key labs like CBC, LFTs, BUN, creatinine. Work to identifying the offending medication through a good medication history. Focus especially on high-risk drugs like anticonvulsants, allopurinol, sulfas, antibiotics, NSAIDs, and antiretrovirals. Most importantly, stop all suspect medications immediately to allow the immune system and skin to begin recovery. Consider early referral to dermatology, infectious disease, or allergy or immunology. Many patients require hospitalization for supportive care and further evaluation. And now, to bring this to life, Debbie will present today's case study.
Hello, my name is Debbie Davila. I'm a nurse consultant with the Heartland National TB Center. And the patient that I'm presenting today is a young adult male that developed a drug reaction with eosinophilia and systemic symptoms while he was on TB treatment. And so a little bit about this patient's background. He resided in the northeastern region of the US with his sister and brother in an apartment. He is foreign-born and moved to the US in 2023. On May 22nd, 2024, he went to the emergency department with fever, cough, and respiratory symptoms. A chest x-ray was done and showed right upper lobe patchy opacities, and he was diagnosed with community-acquired pneumonia and discharged with augmentin and azithromycin. Then 2 weeks later, on June 4th, 2024, he presented to the hospital again with progressively worsening symptoms, including generalized weakness, night sweats, and a persistent cough. Of particular concern for him was the recent onset of blood in his sputum. He had initially attributed this to smoking a marijuana cigarette a few days prior, which he suspected may have been mixed or laced with another substance causing the bloody sputum. Due to the persistent and escalation of symptoms, he sought medical evaluation for further investigation and treatment. Findings from the June 4th hospital visit showed worsening chest x-ray with bilateral opacities. The CT noted extensive bilateral micronodular opacities with cavitation and mediastinal and hilar adenopathy. A sputum specimen was collected and was AFB smear positive. The PCR was positive, and no rifampin resistance was noted. They also did a Q of T, which was positive. His HIV and hepatitis screen were both negative, and his labs indicated that he had normal LFTs. So he was diagnosed with active TB disease and started on RIPE with rifampin, isoniazid, pyrazinamide, and ethambutol, which was started on June 6, 2024. He tolerated these medications well during the hospitalization with no complaints and no problems reported. Then he was discharged from the hospital on June 11th with 30 days of RIPE and was instructed to self-isolate until he followed up with the health department. Following his hospital discharge on June 11th, the patient was referred to the local health department to continue his TB treatment. So from June 17th through June 21st, 2024, he received TB treatment via directly observed therapy, or what we know as DOT. And then he was transitioned to VDOT, or video DOT. Then on July 8th, the patient traveled to visit his family in the South, and during the visit, family members observed that the patient appeared weak, had a poor appetite, and was experiencing a rash along with fever-like symptoms. The patient was taken to the hospital for further evaluation. The evaluation noted a diffuse maculopapular rash from foot to chest, mostly in the torso. He had no palmar or plantar involvement. Lab findings indicated elevated liver enzymes with an AST up to 1,000, the ALT 1160, a total bilirubin of 5.4, and he had a mild increase in creatinine to 1.4. And just as a reminder, prior to initiating his TB treatment, which was at baseline, his liver function tests were normal. And the patient also showed signs consistent with sepsis, including an elevated lactic acid and an elevated white blood cell count and tachycardia. Further investigation led to a diagnosis of acute liver failure, suspected to be caused by TB treatment. So as a result, RIPE was discontinued on July 9th, 2024. Subsequently, the patient developed acute kidney injury and dialysis was initiated on July 12, 2024 to manage renal function. He also had a renal biopsy done that same day that noted acute interstitial nephritis likely due to rifampin, and this is when the prednisone was initiated with a slow taper. Unfortunately, we don't have a picture of the patient's rash when it first began. However, we did see another patient that Catalina previously mentioned. We saw her around the same time period that we had this patient with this problem. And so she had a very similar drug-related skin reaction, which we were able to document here. As you can see, the patient presented with a skin eruption that includes both macules and papules. You can see the macules here, which are the flat discolored areas on the skin, and the papules are the small raised bumps. The rash typically appears as a red or pink patches that may be slightly elevated and can sometimes merge into larger areas similar to this patient here. Again, this image is an example of the kind of rash that was present in our patient with DRESS. And this lab chart provides a reference point showing that at baseline on June 4th, the patient's lab values were relatively normal. However, by July 8th, approximately 1 month after initiating TB treatment, there was a significant elevation in his labs. His AST had elevated to over 1,000, as did his ALT. His alkaline phosphatase was to 378. The total bilirubin had elevated to 5.0. And in addition, his creatinine had increased to 1.30. And there was a notable rise in eosinophils, all indicating multi-organ involvement. And TB treatment was discontinued on July 9th in response to these abnormalities. While his liver function tests began to show signs of improvement by July 22nd, after stopping the TB meds, his kidney function continued to decline, highlighting the severity and systemic nature of his reaction. And I'd like to point out that these clinical manifestations can persist for weeks to months after discontinuing the meds, as you will see further into the case study presentation. As Catalina mentioned earlier, while there is no single gold standard for diagnosing DRESS syndrome, the European Registry for Severe Cutaneous Adverse Reactions, or REGISCAR, has developed a widely used scoring system to aid in diagnosis. This system is based on a combination of clinical features, including the extent of skin involvement, the degree of internal organ involvement, and the overall clinical course of the illness. And based on these criteria, cases are classified as definite, probable, or possible DRESS. In the case using the registrar scoring system of our patient who developed a rash after starting RIPE therapy, several key features aligned with these diagnostic criteria. He experienced persistent fevers for several days, with temperatures exceeding 101.3. Lab results revealed eosinophilia, and clinically he developed a widespread rash that was highly suspicious for DRESS. This suspicion was later confirmed through a skin biopsy, and both an infectious disease specialist and a dermatology team saw the patient and they agreed with the DRESS diagnosis, with RIPE being the culprit. Additionally, a kidney biopsy revealed acute interstitial nephritis, further supporting systemic involvement consistent with DRESS. And based on these findings, the patient received a score of 9 on the REGISCAR scale, which categorized him as a definite diagnosis of DRESS syndrome. And here's a timeline of events that have occurred thus far for this case study. On May 22nd, 2024, the patient presented to the emergency department with respiratory symptoms. He had an initial chest x-ray leading to a diagnosis of community-acquired pneumonia. About 4 weeks later, on June 4th, the patient continued to experience symptoms, and imaging studies, including a repeat chest x-ray and CT, remained abnormal. A PCR test was positive for TB. Initial lab results were within normal limits, and as a result, the patient began TB treatment. Then on July 11th, after several days of treatment, the patient was discharged from the hospital, and at the time of discharge, liver function tests were reported as unremarkable, suggesting no immediate concerns. Then on June 16th through the 21st, the patient received treatment by DOT, and this was a 4-day period. And then 6 weeks later, on July 8th, 2024, the patient returned to the emergency department with a number of concerning symptoms, and RIPE was discontinued on July 9th. And this is when Heartland National TB Center became involved with this patient's care. As the hospital was preparing for the patient's discharge, arrangements had already been made with the health department for the continuation of his TB treatment. But there were some ongoing concerns. So on July 30th, 2024, during this patient's second hospitalization, the hospital contacted our center regarding the patient's treatment plan. The hospital reported that they had adjusted the patient's regimen to a liver-friendly regimen, which included moxifloxacin 400 milligrams, linezolid 600 milligrams twice daily, ethambutol 800 milligrams 3 times per week, and imipenem. They also reported that linezolid was temporarily held due to a significant decrease in platelet count. However, the medication was reintroduced and the patient began tolerating the medication without any further problems. The hospital also reported that clinically the patient showed significant improvement. The patient's appetite had returned and he no longer experienced nausea, vomiting, or shortness of breath. Additionally, his oxygen saturation was stable at 99% on room air, and a sputum specimen collected on July 28th was now smear negative. His liver failure had resolved with no further signs of hepatic dysfunction, and radiographically, there was no significant change. However, there were ongoing concerns at this stage with the patient's acute kidney injury, specifically whether it was going to resolve or if it would result in long-term damage, potentially requiring continued hemodialysis. Fortunately, it was later determined that the patient would not need further hemodialysis. Our medical consultant suggested that this patient's condition was likely caused by drug-induced liver toxicity, specifically related to DRESS syndrome. This conclusion was supported by several clinical findings, including acute liver failure, acute kidney injury with biopsy-proven acute interstitial nephritis, likely attributed to rifampin, as well as the diffuse maculopapular rash and eosinophilia. As Catalina mentioned earlier, DRESS syndrome typically develops 2 to 12 weeks after starting TB treatment. In this case, the patient experienced a reaction approximately 6 weeks after initiating the RIPE treatment, which aligns with the expected timeline for DRESS syndrome to manifest. And our medical consultant made several key recommendations for this patient's ongoing treatment. She recommended that given the severe nature of his reaction, this patient should never take rifampin again, nor should any other rifamycin be used, as this would carry significant risk due to the severity of his illness. Additionally, the consultant strongly recommended against rechallenging the patient with rifampin, INH, or pyrazinamide, as reintroducing these medications could further jeopardize his health. Instead, our medical consultant recommended a regimen for rifampin-intolerant TB known as the BPALM regimen, which includes bedaquiline, protomidate, moxifloxacin, and linezolid to be given for at least 26 weeks. So this patient continued on TB treatment, but he continued to experience issues while on treatment, and Catalina will present this next.
Thank you, Debbie. To summarize the case, after the offending drugs were discontinued, the medical team closely monitored the patient and initiated TB treatment. Also, they included corticosteroids to reduce inflammation and prevent organ damage. The patient was discharged from hospital at the end of July, the beginning of August, followed by the health department. Patient was receiving BPALM regimen. In August 30th, patient was readmitted. He had the following symptoms: fever, elevated creatinine of 1.48, swollen face and hands, mild eosinophilia, and both episodes of facial swelling and rash flare likely was linked to rapid steroid tapering. Here, these are pictures of the patient show facial and hand swelling upon readmission. This swelling was likely related to the rapid steroid tapering, which can exacerbate symptoms in some cases. The patient's condition required careful reassessment and adjustment of the treatment plan. These pictures taken on the second day of hospitalization show acute findings such as facial swelling, which are consistent with the active phase of DRESS. In contrast, the scaling lesions on the back suggest the healing process, likely related to the earlier acute rash from July, even though we don't have pictures from that time. As we say before, over time, the rash can turn purple and start peeling. In 20 to 30% of the patients, the redness spreads and covers most of the body. The photos show his back in September and in October. In September, you can still see redness and rash that improve in the October photo. The skin looks better in October, less redness, however, with some peeling. Her feet in September were also swollen and also starting to peel. How was the clinical course and the outcomes of this patient? The patient was reinitiated on BPAL therapy in September following a temporary interruption due to adverse reactions. During hospitalization, dermatology team recommended initiating benralizumab, an IL-5 inhibitor. This is a biologic medication used to treat eosinophilic asthma. It was well tolerated and led to control of the reaction. Patient was subsequently discharged on the full BPAL regimen. He is currently nearing completion of treatment with no signs of recurrence, and laboratory results remain within normal limits. Active TB can be treated successfully despite DRESS using an alternative regimen. Avoidance of the medications causing DRESS is essential. Patients unable to tolerate rifampin had to be treated as if they have multi-drug resistant TB, which meant using second-line medications for 18 to 24 months, often with more side effects. However, with the introductions of the BPAL regimen, treatment has improved. It can treat these patients in just 6 months. This is a big step forward in making TB care shorter, safer, and more effective, especially for patients with DRESS. What is next in treating DRESS? A look beyond steroids. Today, steroids remain the frontline treatment for DRESS, and they save lives. But we also know that long-term steroid use can be harmful. That's why researchers are now studying new medications like the IL-5 inhibitors that may help control inflammation in a more targeted and safer way. Early results are hopeful, and we are excited to follow these new options as they develop. We will be sharing updates in future webinars, so I encourage you to stay tuned and keep learning with us. Now, Salma will conclude this webinar by sharing some key patient education points along with essential teaching takeaways for managing patients with DRESS.
So let's talk about some important education points that we should be covering with our patients that have DRESS. We know that most patients with DRESS recover completely in a few weeks or months after the medications have been stopped or discontinued. We need to educate patients about the need to strictly avoid the offending drug by all means, as well as any other cross-reacting drugs that can continue to induce stress. Unfortunately, months or years after the resolution of the drug reaction, autoimmune diseases have still been reported in some patients, such as thyroid disease, diabetes, autoimmune hemolytic anemia, and a patient will require medical follow-up for several years after DRESS has resolved. So, even if a patient has DRESS, TB disease can still be treated successfully by using an alternative regimen like BPAL, for example. But if a patient is stable, it could be best to wait for the patient's skin to fully heal before proceeding with a treatment, as recurrent DRESS can be mistaken for a reaction to a second drug, which could also occur. So what are some teaching points to take home? Always, always, always think, is this DRESS? When a patient presents with a combination of a rash and facial swelling, think of DRESS as a possibility. You want to monitor and watch your CBC labs, paying very close attention to the eosinophils, your LFTs, and the creatine, as this is really going to help you identify DRESS. And most importantly, make sure to stop all suspected medications that can be causing DRESS and allow the patient's skin to heal. Remember to obtain a detailed medication history, as it's going to be very important to be able to identify medications known to precipitate DRESS. Also ensure that you are conducting a daily evaluation of your patient with DRESS and document all the reactions appropriately and with sufficient detail. You can do this by using pictures, as this can be beneficial because you can place them in the patient's chart, and you're going to be able to track the patient's skin improvements or if they are worsening, you can track that as well. Pictures are also going to be helpful if you find yourself having to submit a medical consultation request with an expert. As mentioned previously, signs and symptoms of DRESS may persist and recur for weeks after the cessation of the offending medication. It's very important that we stress the severity of DRESS and that it does require immediate medical attention, as the fatality rate is up to 10%. The main cause of mortality in DRESS is due to fulminant hepatitis and liver necrosis. Other internal organs could also be compromised. These can include the liver, the kidney, and sometimes even the heart and the lungs. It can be a reaction that can cause severe liver failure with coagulopathy, encephalopathy, and an ALT greater than 10 times the upper limit of normal. It can even end up being so severe that a liver transplant could be required, or cases where severe interstitial nephritis occurs and later progresses to kidney failure, requiring a patient to be on dialysis. Lastly, make sure to seek expert medical consultation due to the severity of DRESS and the probability that many patients with DRESS will require hospitalization. At Heartland, we have created a rash assessment tool, which you can find on our website, as I have displayed here, and I have also displayed the link for our website. So this tool will guide you in properly describing the rash you see on your patient. As seen in this picture of this patient, it is easy to look at the patient's picture, then glance at our rash assessment tool to be able to identify which description best matches how the patient's skin looks. For example, I would describe this patient's skin as a macular papular rash, as I see a flat rash with possible palpable or non-palpable areas. The description guide is going to help provide you with accurate terminology to use for documentation purposes, or if you find yourself having to submit a medical consultation request or having difficulty in knowing how to describe the rash you are seeing in your patient. These are the references that we used for this presentation today. And with that being said, we would like to thank you all for your time and attention. We are open to any questions anyone may have.
Alrighty, and just like that, we have entered the Q&A period of our presentation today. I see that one person, Thomas, or sorry, Keziah Thomas, has their hand raised. Keziah, if you would have the ability to drop your question in the chat, please do so. We can technically unmute you, but I want to make sure that I'm not accidentally like throwing that to everybody on my end, just to be clear. Let's see. I don't have anything in the chat other than a whole bunch of kudos for our Heartland nurses because they deserve it. They're amazing. I just want to say, oh, Martha asks, is the PowerPoint available to be downloaded? And Martha, I can tell you that it will be available to be downloaded. Usually we have the recording and the final version of the presentations ready to go within our training archives page on our website in about a week or so. So just stay tuned, keep that in mind, and just know that we are working on it. Let's see. And then Melinda asked, will the PowerPoint be available for others? Yes, via the training archives page. Let's see. Oh, I do have a question for the nurses in here from Alana. So ladies, how old was the patient and did the client have underlying medical health conditions?
The patient
Hello.
was 34. Oh, go ahead, Debbie.
No, go ahead, Catalina.
I think the patient was a 34-year-old Hispanic male with no any other comorbidities.
All right, and then we have Darlene asking, was there any consideration for extending treatment due to the meds that the dermatologist wanted to add to the regimen?
Extending treatment due to the meds. As far as I know, the patient just received BPAL, the 26 weeks of BPAL. I think extending the regimen was not a recommendation by Dr. Seward.
And I think right now he's doing so well that there isn't a plan to extend the treatment. He's been tolerating the medication well, and dermatology has been following up with the patient.
All right. Jennifer asks if we have the website for Heartland to pull up pictures of dress. I don't believe that we have any pictures of dress available on our website, but ladies, can we reach out to y'all if you have any good examples?
I went ahead and added
Mhm.
our website because I wasn't sure if she was referring to the pictures on the dress product, on the
Oh,
rash
gotcha.
assessment product.
Yes, yes. Okay, yes. And the rash assessment product is actually within our products page, and it's available for download. And it makes a really great printable if you do it on both sides. So then next question comes from Martha. She asks, are there any studies that suggest autoimmune you'll have to correct me because remember, I don't have a nursing background, ladies. DX is diagnosis, right?
Yes.
Yeah, so are there any studies that suggest autoimmune diagnosis results in higher risks for dress?
Yeah, there are studies, and probably one of the references that we use, maybe they can, you can find studies about that. However, if you want, I am always looking for those studies I can look at and maybe send it to the person who is asking for.
Yeah, so that would be Martha Seville. So just write it down on a sticky note. Now I'll send that to you, Catalina. Let's see. Next question. I'm just scrolling down in the chat. Oh, Olive. So if you can't see the Q&A pod, you can absolutely drop it in the chat if you have a question. But otherwise, question from Martha, are we able to offer these treatments when we have TB patients who are interested in treatment, but their LFTs don't look so good?
So we have Dr. Armitage on the who's joining us, and maybe she can comment on that.
Let's see. I can unmute Dr. Armitage, I think, since she's a part of the UT Tyler group. Let me see. Let's see. Dr. Armitage, if you should be able to unmute yourself.
Can you hear me?
Yes.
That's funny. I think secretly the nurses and Lauren probably want to mute me sometimes, but
No.
I have been released. Watch out. No. So there's, the treatments for the TB drugs generally kind of drop into two baskets, and that's the, those that are cleared by the kidneys and those that are cleared by the liver. So most of the time, yes, if the patient has active TB, we're not going to surrender them to the disease. We're going to work with a few tools that we have and just kind of move some things around. Sometimes there are IV options, like the patient that was here was on imipenem while he was in the hospital. And then, the fluoroquinolones, levofloxacin is cleared. Levofloxacin is cleared through the kidneys, while moxifloxacin is cleared through the liver. So you frequently will have some options one way or the other in trying to divide them up. But yes, we have yet to find a patient that we absolutely could not treat because of either reactions or liver liver toxicity or even renal failure. We've always seemed to be able to come up with one. With some of them are on weaker regimens and we've been a little bit nervous about, but just to answer your question, we personally at Heartland and Barbara Seaworth's 25, 30 plus years of doing this have not found a single patient that we could not offer some effective treatment. And I do want to tell you, Lauren, there's a question in the Q&A pod.
Oh, there is. Okay.
That you
All
may
right.
not have
I'll go
seen.
visit that. All right. While I go take a look over in the Q&A pod, I do have another question in the chat from Jeff. Jeff asks, is DRESS only associated with ATBD, or does it occur with LTBI treatment as well? Specifically, TB infection patients taking rifampin.
I think it doesn't have to be with latent TB or active TB. It has to be with the medication more. It's because of the rifampin or any other medication, but it doesn't have to be with certain LTBI or active TB disease. I don't know if Dr. Armitage has something to say, but it's more related to TB meds, medication.
We haven't had one yet with LTBI treatment, but that doesn't mean it can't happen. I would still be looking.
All right. And then Padma Priya, I'm correct. I'm so sorry if I got your name wrong, but you have a really good question. All right, ladies, here it comes. What if the DRESS patient became reactive to linezolid, for example? What would be an alternative in that case, other than cry?
Again, we're answering the nursing questions, and we have the consultant here with us, thank God, to answer that question. So.
Oh my goodness. What I would do personally is walk down the hall to Barbara Seaworth's office and start asking some questions. That's what I would do. But no, again, there are some MDR regimens that have looked at, because of the toxicity associated with linezolid, pulling that particular drug out. But it's that is really the bedaquiline and linezolid are cornerstones of the MDR regimen. Anything beyond that's allowing us to shorten it to 6 months. But all of them together, the protominate plays a very important role. So bedaquiline, protominate, and linezolid. If one of those drugs go down, in all likelihood, you're going to have to replace it with 2 other drugs, and you're going to have to extend treatment. If you can keep bedaquiline in that regimen, that is really about the most important one of the 3. If you can have moxifloxacin in there as well, you can likely find another replacement for linezolid. But just, then you're just looking at treating the patient long enough to be able to, to be able to get them to cure. But those are some good questions. And there are a lot of regimens, including going back to Old Faithful PZA and looking at different medication options for just getting a strong enough regimen to get the patient to cure.
All right. Well, I'm pretty sure that I've addressed all the questions in the chat, and it doesn't look like we have any further questions submitted to the QA.
Lauren,
Yes.
I just want to thanks Dr. Bibinagar. She just put in the chat. She was the one who was treating the patient as an outpatient in Dallas. So Dr. Bibinagar wrote that they decided to extend the treatment to 9 months because of the severity of the TB that the patient had. So she was the one who shared with us the pictures of the patient. So thank you so much, Dr. Bibinagar, to add this to the chat and to the case study.
Whoop, whoop. All righty. Like I said, it doesn't look like we have anything new dropping in the chat just yet. Let's see, Pamela, you don't see the rash assessment tool in our website's products. I can definitely drop a link to that in the chat here in just a moment. Oh, Dr. Bibi Nagar asks, which autoimmune conditions are most frequently reported after DRESS resolution? Oh, and thank you, Laura, for dropping it in the chat for me. That's so kind of you.
And Lauren, just really quickly, I think it's in the consultation area of our website. I don't know if it's in the product.
No, it's on the product section.
Okay.
Yes, all the way at the bottom.
Okay.
All right, and then back to the question. Which autoimmune conditions are most frequently reported after DRESS resolution?
As Salma said, the thyroiditis, diabetes, autoimmune hemolytic anemia, they are the ones that we found in the studies. But maybe there are several autoimmune diseases.
All right, and then another last minute question comes from Anne, who asked, how long was the patient on bedaquiline?
He was intended to be 26 weeks, but because of Dr. Bibinagar mentioned, probably he was prescribed maybe until 9 months. That is a question that I don't know the final answer.
Gotcha.
I believe he started bedaquiline in September.
Mm-hmm.
September 2024.
Lauren, there's a question from Maria Merrick that's a little higher up than the ones that you're looking at.
Oh, is there? I'm so sorry. I didn't mean to. Oh, yep, there sure is. All right. Thanks for the catch, Dr. Armitage. So Maria asks, in suspected DRESS and INH-resistant TB, oh boy, we moved to rifabutin, ethambutol, and levofloxacin. Complicated now by renal failure and insomnia. Man, you can't catch a break. Suspect that levofloxacin was the case. If it fails moxifloxacin, is BPAL next and really needs to be 12 to 15 months if lesion is cavitary?
It
At
sounds
this-
like a consultation.
Right.
Right.
Yeah. At this point, I would stop all rifamycins and get a consultation. I'd absolutely be fearful in a particular patient where you're suspecting DRESS and using another rifamycin, even a different one. So we've done that before, with switching from rifampin to rifabutin in very select cases, but never in a patient with severe disease. So I'm like Catalina. I think that I would highly recommend that you stop rifabutin right now, stop all of the medications, and pursue a consult with your COE.
And then an update, Dr. Bibi Nagar dropped for our participant who's asking about how long the bedaquiline was in play. The patient is still on BPAL at this time, and they plan to continue until the end of July of this year, so about 9 months or so. Elizabeth asks a question. Her question is, does a rash always have to be present for a DRESS diagnosis?
Yes, it's one of the differential diagnoses. Rash has to be present.
All right. And then at this point, because we are coming up on our ending time, I'm going to go ahead and remind everyone that both Catalina, Devi, and Salma all have their contact information listed on our website. And of course, please feel free to reach out to any Heartland team member. And if you don't already have them, we will go ahead and share their contact information with y'all. Now, just a couple of end of course business to take care of. I do want to make sure that we are aware of how we can get our lovely CEs, because I know that some of us really, really want those. So if you really want your continuing education, just know that you need to complete the assessment and the evaluation via the QR code and link below that are presented on screen. I will leave this up for quite a long time, so please feel free to take your time with writing it down. Just know that once you initiate it, it is timed because of the fact that the assessment is in there for 60 minutes. And once that 60 minutes has elapsed, that is it. So if you didn't quite get that last question in there, just know that it will time you out and that will be marked as an unanswered question. So I do want to be clear and upfront about that. Once you start, that 60 minutes is counting. Now, as far as the actual assessment is concerned, it needs to be 80 or higher in order to pass, and it must be completed by the end of the day today. And then if you do happen to successfully pass for the assessment, please allow up to 14 days from the end of today's event to receive certificates. They will be sent out via email, but it does take a little bit of time to do so. So just know that that clock starts for us too, the moment that the assessments are done and over. If you are unsure at any point about whether or not you are eligible to receive certificates, please feel free to reach out to myself. My contact information I will drop in just a moment here in the chat. But as of this time, that concludes our webinar. And I just want to say thank you so much for all of the amazing work that y'all do. It would be remiss if I did not make sure that all of our wonderful people here, as well as within NTCA and NTNC, that we so very much value how amazing and important the work that y'all do is. Or sorry, that sentence came out a little weird. Essentially, I was trying to say that you're all superstars in our books. And so if no one has told you how amazing and appreciated you are yet today, just know that we're saying it now. So just remember, we're always here. We're always on your team as far as making sure that you feel supported as with the important work that you do. And with that being said, I'm going to go ahead and wish everyone a wonderful rest of your afternoon or whatever time frame you happen to be on. So take care, stay safe out there, and have a wonderful rest of your day, everyone. Bye.
Thank you so much, everyone.
Yes, thank you. Have a good day.
Thank you.